Well, the meeting has been quite far-reaching. I'm speaking later today about targeted therapy, and I think the specific topic that I was given is a basket full of targeted therapies, how useful. And so I will be talking about several therapies that I think actually have the potential to be quite useful. I'm going to be talking about some of the recent data with the PARP inhibitors in both patients who have BRCA-associated breast cancer and patients with triple-negative breast cancer. And then I'm going to focus on a couple of the newer therapies for HER2-positive breast cancer, specifically HER2-positive breast cancer that's resistant to trastuzumab, and in some cases lapatinib. And that's an area where I think we've made substantial progress over the past 5 to 10 years, and where we can all look forward to a great deal more progress in the next several years. And then finally, I'm going to briefly talk about PI3 kinase and the promise of PI3 kinase inhibitors, although that is still far, far more preliminary, since at this point in time we only have phase 1 trials. So I think that there is great promise in terms of targeted therapy. That said, we will undoubtedly explore many targets that turn out not to be useful, both because in some cases we may not have the appropriate inhibitors of those targets, and because in others, while the targets on a preclinical level may appear to be important, in terms of human breast cancer, they simply may not be driving the behavior of the cancer, or to put it a way that is often used, the cancer cell may not be addicted to that target, may not really need that particular target or that particular growth factor pathway, for example, to grow and flourish. Targeted therapy doesn't necessarily mean side effect-free therapy, and of course this brings up a related question, which is chemotherapy going away? And chemotherapy isn't going away anytime soon. I think we would all like to think that what the future holds is a time when we will have effective therapy that has no side effects, whether that's because we better manage chemotherapy-associated side effects, or whether that's because we developed targeted therapy without any side effects. But I think it's a misnomer to think of targeted therapy as side effect free. It's for a couple of reasons. One is because sometimes the target isn't so very well defined, and there are these off-target effects, or the drug may actually have a few different targets. The other is that some of these targets turn out to be targets that are on normal cells in the body, not just on the cancer cell, and we have to be watchful for that too. I think the general direction, however, is one where we really have stopped thinking of breast cancer as one disease. We recognize it as a family of diseases, as perhaps 4 or 5 distinct entities, but that even within those distinct entities, there are many, many subgroups and targeted therapies that may be useful in one subset of patients with HER2-positive breast cancer, but not useful in another. And the more we can individualize, the better we will be, because what it'll mean is that we'll be able to eliminate unnecessary therapy from those who don't need it and provide the appropriate therapy to those who do.